Welcome every morning with a smile. Look on the new day as another special gift from your Creator, another golden opportunity to complete what you were unable to finish yesterday. Today will never happen again. Good morning, respected dignitaries and the delegates. After the very interesting yesterday's session, we welcome you wholeheartedly to the second day of SPEEDCON 2022. For the first session today, I take the opportunity to invite our respected chairpersons, Dr. N. Jha, Senior Consultant Physician, Fortis Hospital, Dr. Naresh Khanna, Consultant Physician and Diabetologist, Dr. Pavan Goyal, Consultant Physician and Chairman of IMA AMS Haryana State.
Very good morning. Though we have got thin attendance, but I think it will pick up gradually. And today are very important topics, two very common topics. We are using these two drugs, Glycoside in the normal working and the extended release, as well as metformin in both the forms. And there is a fixed dose combination of these two drugs. It has found favored with the doctors very nicely. So to speak on this, so what is the position of this Glycoside and metformin as an FDC, fixed dose combination? For this, they're going to speak, invite Dr. Sunil Kota. Then Kota is from Odisha, that much I know. He is an endocrinologist, renowned endocrinologist in Odisha. So I invite Dr. Sunil Kota. He is MD, DNB Indo, and is a diabetes endocare clinic in Brahmpur, Odisha. I met him just before the conference. So I request Dr. Kota to start his proceedings.
Thank you so much, sir, for those words of introduction. We belong to the same part of the world, eastern part of India. So nice knowing you, and thanks to the organizers for having me here and asking me to talk about this position of glycoside and metformin in the evolving landscape of type 2 diabetes. To have a preamble, we all know that India has currently a prevalence of 9% and around 74 million people are having diabetes as of now. And at the same time, recently there was a paper from Dr. V. Mohan et al. Who told us that around 70% of people are not reaching their goals despite our best of efforts, and the average A1C according to several studies is hovering at around 8.5%. And also we know that diabetes is a progressive disorder. The monotherapy is bound to fail. You would require addition of a subsequent drug, but then polypharmacy and complex dosing regimens are the ones which are acting as a big deterrent to the patient's adherence to therapy. So with this preamble, I am going to start off with the topic proper. These are the points based on which I am going to take you through. So first of all, why exactly do we require a fixed dose combination? So this slide we have seen it a number of times, and time and again we are taught by our teachers and seniors that the metformin is the first therapy to start because of our wealth of experience with this drug. It is cheap. It is associated with weight loss. There is no hypoglycemia, and there is also vascular risk reduction as evident from the UK PDS study. But if you look at the guidelines, the ADA, ESD, all of them this tell us that if the person is not achieving A1C under target with 3 to 6 months of monotherapy, you need to upscale the therapy. And look at the UK PDS 49, which says that once the patient is on metformin monotherapy, 5 to 10% patients per year would go on to fail subsequently. Look at the finer details. It says after 3 years, 50% of patients receiving monotherapy would require addition of a second drug, and at the end of 9 years, a whopping 75% people would require multiple therapies to achieve target A1C. So this is a meta-analysis of 15 RCTs published in 2014 in diabetes, obesity and metabolism. And they were trying to look at 15 RCTs who were trying to look at the benefit of combination therapy, and metformin was added on to number of drugs, the thiazolidines, gliptins, glinides, gliflozins, and it is clearly told to us that the combination is better placed as far as A1C reduction is concerned, as far as fasting blood sugar reduction is concerned, and also the proportion of patients achieving A1C less than 7% is also increased. Potentia of drugs, we all know metformin and sulfonylureas are blessed with A1C reduction of 1 to 2%, and rest all we are very much aware of. But then the basic teaching that there is an insulin secretory dysfunction and there is insulin resistance, both these can be adequately addressed when you go for a combination of sulfonylurea and a metformin. So why exactly glycoside? So we are going to briefly talk about the attributes. This again is very well known to us that the glycoside is the one which is very much specific to pancreatic beta cell, acting only on SUR1 Ki 6.2. And look at the table at the bottom, it says the selectivity towards beta cell and the pancreas to heart selectivity ratio speaks very well in favor of this molecule. And the glimepiride, which again is a very commonly used molecule, you can see it acts additionally on the SUR2A Ki 6.2 and the cardiac and skeletal muscle, and also acts on the vascular smooth muscle SUR2B and KIR 6.1. And glycoside is known to be mimicking normal insulin biphasic secretion. It also improves the first phase insulin secretion. It does not change the secretory burst or frequency or regularity, but then it concurrently increases the pulse mass and basal insulin secretion. This is a study in 2008, and look at the yellow graph versus the blue column, blue and yellow columns, and you can see the percentage rates of apoptosis is significantly lesser if the patient is on glycoside. In fact, glimepiride compared to control is associated with higher rates of apoptosis. And pleiotropy is the buzzword of the day. We want the molecule to do wonders to us, and as far as extra pancreatic action is concerned, it enhances insulin sensitivity, therefore increasing the uptake of the glucose into the muscles. There are few studies which tell us that if you add glycoside to insulin, the insulin requirement goes down, and also there is a reduction of fasting glucose without any rise in fasting plasma insulin. Vascular protection, it prevents endothelial apoptosis by reducing oxidative stress. There is reduction of lipid peroxidation markers, increase in superoxide dismutase. There is a study which tells us that glycoside also increases the vitamin E levels in blood, and apart from that, there is a comparative study between glimepiride and glycoside which says that glimepiride is actually associated with increase in lipid peroxidation, which is actually getting reduced with glycoside. It reverses the endothelial dysfunction, it improves the nitric oxide mediated vasodilation, and also it has anti-atherosclerotic benefits. It inhibits monocyte adhesiveness to vascular cells. It inhibits the inflammation associated with atherosclerosis. The interleukin 6, TNF alpha level goes down, the anti-inflammatory adiponectin also goes up. Anti-thrombotic effect, it inhibits the ADP-induced platelet aggregation. It also reduces the plasminogen activator 1 inhibitor 1 levels. The endothelial progenitor cells are ones which are known to be slowing the development and progression of diabetes vascular complications. In states of diabetes, there is a reduction in the number, and also the function is also getting hampered, the proliferation, adhesion and migration. This is a small study where 47 patients were included, and when glycoside was added as a second drug to metformin, the number and function of endothelial progenitor cells went up. And what about sulfonylurea failure? In fact, recently I was pitted against one of my close friends to talk about sulfonylurea vis-a-vis other molecules like gliptins and gliflozins. I was surprised to find an article which tells that the sulfonylureas do keep their efficacy intact even after 70 to 20 years of usage. And in this study tells us that vis-a-vis glibenclamide, the glycoside is associated with longer time to insulin treatment, 27.7 years with glycoside versus glibenclamide it is 21.4 years. So efficacy of glycoside plus metformin FDC, we have the combination is pitted against either of the molecules used alone, pitted against other molecules used in combination. So I'm not going to read out the tables, but I'm just going to show you the number of studies that this wonderful combination has in its favor. 4 slides just to tell you that the number of studies they have in its favor, and you can see the summary is that A1C reduction is between 0.27 to 1.7%. Obviously it would be higher if the patient is having higher A1C. Fasting of 12 to 67 milligram per deciliter, postprandial glucose reduction of 40 to 96, and the proportion of patients achieving A1C less than equal to 7% is 37 to 47%. And glycoside is better placed than other combinations like gliptins, glinides, glitazones and glucosidase inhibitors, but as far as efficacy is concerned, it is as good as any other sulfonylurea. This is durability data which we all have been talking about. 1986 patients from UK clinical practice research data link, and what you can see is that it is compared to sitagliptin over a period of 5 years, it is better placed than sitagliptin as far as A1C reduction is concerned, and very importantly as far as the durability and hypoglycemia, it is found to be as good as sitagliptin. So briefly I would take you through the safety issues. This is the study published in European Heart Journal in 2011 of 1,07,806 patients. You can see as far as cardiovascular death is concerned, metformin is neutral. Glimepiride is associated with 32% significant increase in CV death, but glycoside is associated with 13% insignificant risk reduction. As far as MI, stroke and cardiovascular death is concerned, metformin is neutral. Glimepiride is associated with 29% significant increase and glycoside is associated with 14% insignificant risk reduction. And this dates back to 2007. They have tried to look at the cardiovascular mortality vis-a-vis glibenclamide. There is a 50% lower all-cause mortality and cardiovascular mortality. And this is an Indian study published in DRCP 2008. The coronary artery disease risk is 0.44-fold with glycoside compared to glipizide and glibenclamide, who have risk of 2 to 2.4-fold. This is a study which of around 6,738 patients who were first time hospitalized for MI, and they were trying to look at the drug prescription 90 days prior to hospitalization. You can see the fatality rate is significantly lesser with glycoside vis-a-vis glimepiride. Nationwide cohort study published in Cardiovascular Diabetology 2010, 9,876 patients. Glimepiride was associated with around 20% increased risk of cardiovascular mortality and non-fatal MI. Glycoside was found to be CV neutral. And as far as risk of cardiovascular mortality is concerned, it is around 35% enhanced mortality with glimepiride vis-a-vis glycoside, which is found to be neutral. And this is a very recent one in 2015. Systemic review and network meta-analysis of 1,67,000 patients. The cardiovascular mortality is getting reduced to the tune of 40% significant. Glimepiride is found to be neutral, and as far as all-cause death is concerned, there is a 35% significant risk reduction with glycoside. And Russian study, small one, glycoside is compared with other combinations, and after 12 months, combination with glycoside showed a reduced risk of developing cardiovascular complications like ischemic heart disease, risk of death from ischemic heart disease, risk of acute cerebrovascular event and death due to that particular event, decreased arterial hypertension, and also reduced diastolic dysfunction. Advanced trial, we all know the glycoside was used. There was a 6% reduction for major macrovascular events, 14% reduction of major microvascular events. Also, there is a 21% reduction in the risk of nephropathy. And if you try to look at the finer details, there is a reduction of new microalbuminuria, new macroalbuminuria, new worsening nephropathy. All total, the renal events are getting reduced to the tune of 11%. And end-stage kidney disease, as per this trial, which is defined as dialysis or renal transplantation, there was a relative risk reduction of 65%. So that basically asked the KDOKI to present the guidelines subsequently, which says that glipizide and glycoside are the ones which do not require any dose adjustment. Hypoglycemia is an issue with sulfonylureas, but the other sulfonylureas, they activate the EPAC2, which acts on the downstream RAP1 to give rise to insulin granule exocytosis, whereas we know that the glycoside is the one which does not get attached to EPAC2. So therefore, there is no insulin granular exocytosis. Therefore, the hypoglycemia should be theoretically lesser compared to glibenclamide. It is well known that yes, the hypoglycemia rates would come down by 50% as per this study on 289 patients. But vis-a-vis glimepiride, as per this guide study, there was a 50% fewer confirmed hypoglycemic episodes with glycoside MR versus glimepiride. Ramjan, it is a tough time, And here also what you can find is that the percentage of symptomatic hypoglycemic events were lesser in favor of glycoside, 14% vis-a-vis glimepiride, glibenclamide, glipizide, which hovers at around 16 to 27%. And this is a good one where it is a meta-analysis of 9 clinical trials. Glycoside was compared with other insulinotropic agents like glinides and gliptins. There was no difference in hypoglycemia between glycoside, gliptin and glinide, whereas glycoside was associated with higher A1C reduction. And in comparison to other sulfonylureas, there is similar A1C reduction, but the hypoglycemia risk was significantly lower, which is 53%. This again is 2014 data of 25 studies. Glycoside showed 11 times less hypoglycemia compared to glimepiride. This is the Daya-Ramjan study where around 255 patients from India were included, and the crux of this study was that glycoside XR significantly reduced A1C with no incidence of hypoglycemia in Indian patients with type 2 diabetes undergoing Ramjan fast. Weight gain, this again was something surprising. Steadfast study where glycoside was compared with that of vildagliptin. In fact, both the groups showed 1.1 kg weight reduction. So what about the guidelines? And this is just a list of all the international guidelines. Those have been endorsing the usage of sulfonylureas, the ADA, IDF, NICE, ISPAD, WHO, EASD and AACE. We all know this, that yes, you have to be patient centering and based on the baseline condition you have to treat the patient, but then AACE also says that it also has to be glucocentric. As the A1C goes up, you have to use a drug, probably a dual drug, to get the sugars under control. Similarly is this sentence endorsed by the RSSDI ESI recommendation by 2020. If the glucose control is not achieved, based on factors from A to F, you have to use different drugs, and sulfonylurea is very well placed in this guidelines. And similarly the guideline from the ICMR 2018, there is a recommendation for metformin plus sulfonylurea whenever there is a high baseline A1C or if there is a failure to metformin monotherapy. This is interesting. 2017 WHO list of essential medicines, it only mentions glycoside. And what about the national guidelines? I can't count the number of nations who have been endorsing and using the sulfonylureas. You can see it on the slide. The international task force led by Sanjay Kalra sir, you can see the modern sulfonylureas like glimepiride and glycoside MR are effective and safe second line agents in patients who have not achieved pre-decided glycemic targets with metformin monotherapy. Whenever there is a baseline A1C of more than equal to 7.5% who do not respond to lifestyle modification and metformin, this is a wonderful combination. It can be used in combination with all the OADs except glinides, and they have better safety profiles, especially the modern sulfonylureas compared to the older sulfonylureas. So is the statement by the SAFEs published in the IJEM. Because of reduced CV mortality, better CV outcomes and renal protection, these modern drugs should be used. And again, few of the guidelines like the Dutch, the South African, the stable coronary artery disease, they endorse usage of sulfonylurea and they go on to specify glycoside only. So this was again led by Sanjay Kalra sir, published in 2021. It was a single interaction modified Delphi based study including 338 endos and diabetos. Participants using a 9-point scale were asked to rate 8 statements comprising of a total of 52 items, and the expert panel preferred glycoside as monotherapy or dual therapy in patients, and the reasons attributed were its efficacy, long-term glycemic control, favorable renal outcomes, CV safety and an optimal safety profile. So that brings me to the conclusion. We have a number of positive attributes to this wonderful molecule. There is a glucoconfidence. We do rely on its efficacy to reduce the glucose safety, the cardiorenal safety, and also the lesser incidence of hypoglycemia, and also cost effective, which accounts for its gluconomics. So we understand that the number of drugs, the number of guidelines suggest the use of combination therapy of sulfonylurea plus metformin, and FDCs would actually improve the adherence and the response to treatment. The glycoside, why it is picked up? It is beta cell specific, acts on both phases of insulin secretion, has less hypoglycemia and weight gain, and the pleiotropic benefits which are being touted a lot with the new molecules, that is also there with this particular molecule, like antioxidant, anti-inflammatory and anti-atherosclerotic. It also provides better glucose sensitivity, low hypoglycemia, nephroprotection. And you could recollect the number of slides that I have taken you through the tables, having multiple studies where it was found to be effective and tolerable, and the expert consensus based opinion justified the role of glycoside in different clinical situations. Thank you all for the patient listening.
Thank you, Dr. Sunil Kota, for nice coverage of the topic, and he has extensively covered all the points that it reduces endothelial dysfunction, nitric oxide dysfunction in diabetic patients, A1C reduction, fasting PP reduction, postprandial reduction in blood glucose. It is cardiovascular and renal safe, and there is less risk of hypoglycemia, and it is safety issue that it doesn't cause much weight gain, and it has got better safety profile, better efficacy, and it is also reduces CV mortality, and it is safe in the renal patients. So he is very, thank you, Dr. Sunil Kota.